Thank you very much, and my apologies that you have to put up with me again here. So this is, I thought about titling this "Welcome to the Data-Free Zone," and at least in terms of randomized prospective data, this was a tough thing to put together, I thought, because there's a lot of data, but there's a lot of retrospective and population-based data, and finding out what's good and what's not was challenging. Oops, So again, the classic epi slide to begin with. So less than 1% of appendectomies will have cancer. And so that's been reported anywhere from being not existent in routine appendectomies up to 0.7%. This was a pretty impressive slide. This was actually from Northern Africa, I'd like to say Morocco. Almost 25,000 appendectomies, and were all obviously for all possible indications. Almost 1% of them had a malignancy. Oftentimes an incidental one just at the time of appendicitis. So this year has found about 0.12 cases of appendiceal malignancies per 100,000 per year. And so this is a rare tumor. And the most commonly mucinous adenocarcinoma, similar numbers from the Netherlands. So the confusing thing with appendiceal cancer is really the pathology. And so there is a lot of terms out there that have been floating around. And I think there is now definitely a consensus coming together on how to classify appendiceal neoplasms. There are some really neat papers. And if you really want to dive into this, the one by Carr here in Histopathology last year is really truly an outstanding paper on the topic. So, so I'm going to go through a few of these classifications. So one is appendiceal mucinous neoplasms, or AMNs, without the infiltrative invasion. Of them, the low-grade version, the lamin, is by far the most common. And so that's what we will see a lot of times. We can have just regular adenocarcinoma, which is invasive, infiltrative, and has potential to metastasize, which can be mucinous with or without signet rings, or can be non-mucinous with or without signet rings. So this comes in all sorts of flavors for you. And so then we have the mixed adenoneuroendocrine carcinomas, the MANECs, which just got renamed, and I'm just blanking on the new name of them. There's a new classification, oncology classification, forthcoming from the WHO next year, so they'll probably have a new name. And goblet cell carcinomas, we'll talk a little bit more about those. There's a lot of misconception about those. These are not neuroendocrine tumors. And then we have the neuroendocrine tumors, which are near and dear to my heart, and then some rare stuff, including GISTs. So moving on, so I won't dwell much on this one. This is from the paper by Carr that I highly recommend you take a look at. And what I was going to focus on is the lamin, the low-grade appendiceal mucinous neoplasm. And then we also will spend some time on the real adenocarcinomas, because these are probably the most common and definitely the most challenging in terms of oncological management. So just going through another complicated slide here, and the reason I put this one up there, and obviously this is all in the handout, is to just introduce you to a couple of terms that you will see floating around. And one of them is DPAM, and then another one is PMCA. So these are mucinous carcinoma peritonei, and these are older terms that have been floating around there, and that we are not using nearly as much anymore. So, classification and histology matters. And so what I wanted to show you here is from two studies. So this is a large registry study. I think this was either SHEAR or NCDB. So we're talking serious numbers. And so this is all stages of appendiceal tumors. The red ones are the neuroendocrine tumors, the carcinoids. They do well. The green ones are the signet ring cell adenocarcinomas. They do not do well. And then the MANECs and the goblet cells fall in between. If you look at the stage 4s, you see that by far the appendiceal neuroendocrine tumors, which are not that common, by the way, and they do pretty well even for advanced disease. We're seeing that this is on a scale up to 18 years. And you see that the metastatic MANECs, carcinomas, and the goblets don't do well. They seem to do fairly poorly. Well, this is another similar study looking at regional disease, which by SEER is either a T4 or node-positive disease, and you can see that the neuroendocrine tumors do well. So they are in up to 0.3% of all appendectomies, and the incidence seems to be going up, slightly more common in women. Generally, indolent malignancies, they generally do not metastasize outside of the abdomen. And the presentation, oftentimes appendicitis-like presentation, or just the mucinous ascites, jelly belly with the new hernias, that sort of stuff. And they do overlap with other appendiceal cancers. You can sometimes think of these almost like a spectrum where the lamins are on one end and the high-grade adenocarcinomas on the other end. And you can put the same slide in front of 3 different pathologists and they will read them out differently. And, but the concepts of therapy are generally dictated by the histology, so you need a GI pathologist you trust. And if it's a lamin, local regional therapy really is the mainstay of the therapy. High-grade tumors, it's multidisciplinary with systemic therapy. So moving on here. So pseudomyxoma peritonei, PMP, it's a syndrome, it's a clinical syndrome. This is not a cancer per se. And these are mucinous neoplasms that grow in the peritoneal cavity, fill it up with the gelatinous fluid. And you often see omental caking with that. But there are other tumors than appendiceal tumors that can cause it.
Just a couple.
So a little bit on the pathology here. So IHC is usually diffusely positive for CK20, often for CTX2, and frequently CK7 negative, sort of like a colon cancer profile. And they tend to be KRAS, often KRAS GNAS mutated, rarely BRAF mutated, and rarely mismatch repair deficient. And sometimes markers can help. So in terms of therapy, so for localized low-grade mucinous neoplasm resection of all disease, simple appendectomy for early-stage disease, and even if the proximal margin is positive, recurrences are not that common. The problem is what to do if mucin spills into the abdomen. This is where you need a good surgeon again. So our peritoneal surgeon, he actually does a diagnostic lab 12 months later if there's mucin spillage. And he actually does it for a lot of patients just to look around to see if there's persistent disease. And you should consider a right hemicolectomy for selected patients, definitely with larger tumors, more than 2 centimeters, higher grade histology, and lymphovascular infiltration. Adjuvant therapy is not indicated after simple appendectomy or right hemi unless there's a higher grade you find out there with the signet ring cells or node positivity. Then you can consider it. So as for the surgery, it's a cytoreductive surgery for the pseudomyxomas, and these are extensive. Obviously, long surgeries can be 8-10 hours long. With hyperthermic intraperitoneal chemotherapy, it's not a standardized procedure. You can look at a lot of different centers across the globe, and you see that people are doing things differently. We most commonly use mitomycin C, but here are some of the other drugs used. And the 5-year overall survival for the lamins is really outstanding. So there was a large study, more than 2,000 patients, multiple different centers, retrospective, overall survival of 16.4 years with metastatic cancer. That is not bad. Progression-free survival of 8 years, and this can be repeated. So this just shows the outcomes, and these 2 numbers here, the CCR0, these are the resection rates, R0, R1. You see they do well. Those who have sort of major debulking where you can't really get most of the tumor out, they don't do that well. But look at the x-axis here. So this is months. This is really, you can see that the surgery here, surgery with HIPEC, this is 10-year survival. So this is really good. And this here was meant to show the outcomes of redo surgery for recurrence. Just this is a similar scale here, 120 months out here. So you can see even if you re-operate on them and re-HIPEC them, you can get good results. So what about systemic chemotherapy? For higher grade, more aggressive tumors, you can consider pre-operative chemotherapy. It has been associated with worse survival. I think that's all selection bias. And then you can consider it in higher grade tumors. Palliative chemotherapy, no prospective studies. I have not generally found this very helpful, but I have used it several times. So colorectal cancer-like chemotherapy, 5FU based, and definitely for the higher grade tumors. VEGF therapy may have some activity. And you can get some disease control, but we really don't have good data. So moving on to the slightly more aggressive version of appendiceal cancer. So these are the adenocarcinomas. Still, they are the most common appendiceal malignancies. Still rare though, up to 60%. Nodal involvement is very common. If you look at well-differentiated small tumors, 5% of them have nodal involvement. If you look at poorly differentiated tumors, small tumors, 40% of them have nodal involvement. Moderately differentiated tumors with no lymphovascular involvement, 6% nodal mets. If there is lymphovascular involvement, 40% in nodal mets. Again, you'd really need a good pathologist. So for localized disease, we do resection, appendectomy, followed by right hemicolectomy for those at higher risk of having nodal recurrence based on these findings here. And this slide is meant to show the role of adjuvant therapy. So no clinical trials. This is from the NCDB. So be that as it may, there may be some biases there too. So, but you see that for mucinous and non-mucinous cancers, there is probably, at least according to this, some benefit in adjuvant therapy. So the blue lines are those who got the adjuvant chemotherapy. The red line is the patients who only got surgery. So you should consider this. I wouldn't necessarily consider it for stage 1 or stage 2, but for stage 3, I would definitely consider it. So for high-grade tumors, you can consider CRS, cytoreductive surgery, and HIPEC for metastatic disease, but we like to get some control over these diseases with chemotherapy for a number of months before we even consider it. But this is from Travis Groats, who just recruited to Mayo a few months ago. So he was at MD Anderson, and they looked at outcomes after CRS and HIPEC, and patients with low peritoneal carcinomatosis index actually didn't do that bad. And then there's a study from Europe looking at what's called early postoperative intraperitoneal chemotherapy when added to HIPEC. That seems pretty harsh to me. But it's, you can see that with HIPEC alone versus HIPEC plus EPIC. So there may be some benefit there. So in terms of neoadjuvant chemotherapy, considered for peritoneal disease, definitely we do that fairly frequently. And the treatment is generally similar to colorectal cancer therapy, so FOLFOX, FOLFIRI, that sort of stuff. And we do mutational test these. They can have RAS mutations. We don't know if EGFR-directed therapy has activity. It might actually do harm, according to some studies. And then a possible role of VEGF-directed therapy. So what about systemic therapy, differentiation, and mucin? So you have to look at all of these things. So if you have a well-differentiated stage, let me see if this works. Well-differentiated stage 4 mucinous adenocarcinoma, there might not be much benefit in chemotherapy. These are the top lines there. This is for stage 4 disease. For moderately differentiated stage 4, keep an eye on these top 2 curves here. So the blue curve here is chemotherapy, the red one is not. There's some activity there. And then for the poorly differentiated, for mucinous and actually non-mucinous tumors too, there is some benefit of chemotherapy. So chemotherapy may help, but this is just, these are just large, this is NCDB data. So it doesn't have all of the chemotherapy details. Okay, so now the really confusing stuff. So Manax, goblet cells, and neuroendocrine tumors. The neuroendocrine tumors are simple. These others are actually fairly simple too. So Manax are most commonly seen in the appendix. These are more aggressive than goblet cell carcinomas, probably less aggressive than true adenocarcinomas. And but they definitely behave more like adenocarcinomas than neuroendocrine tumors. So these are carcinomas. The goblet cell tumors, or goblet cell carcinomas, these, if there's one message here, these are not neuroendocrine tumors. These are carcinomas. These are not carcinoids. And these tumors resemble goblet cells of the intestinal tract, and they stain with neuroendocrine tumor markers, but they behave worse. And the prognosis is similar to the Manax, worse than the NET. So they fall sort of along the line of, the Manax, a little better than the adenocarcinomas, definitely a lot worse than neuroendocrine tumors. And the larger the adenocarcinoma component, the worse the prognosis is. And these are often mislabeled, misdiagnosed. So this is a busy slide, but I just wanted to point this to you. So this is the Tang classification of goblet cell carcinomas from Laura Tang at Memorial. So I won't go through all of these details, but there is a way to classify these rare tumors. And if you look at the 3 different types, you can see that the survival is very different. So when I encounter these tumors, which is not that common, I really ask the pathologist to go back and see, can they classify this according to the Tang classification? So how do we treat them? So for the T1s, which are not maybe that common, a simple appendectomy may be sufficient, unless there are high-risk features such as higher grade, poorly differentiated, large adenocarcinoma component, lymphovascular perineural invasion. Then you would do a right hemi, and that will give you all of the nodal staging that you need. And some even recommend a right hemi for all of these. I think that we've been fairly aggressive with right hemicolectomies. We've been looking back, and we will have these data, as Axel said, So we've been looking back at a number of these patients, and we have done a lot of right hemicolectomies for neuroendocrine tumors and goblet cells where there was nothing in the resection specimen and no nodes were involved. So it would be nice if we had a better way of predicting who really needs to lose the right colon. So CRS and HIPEC definitely has a role, carefully select patients. So this is where multidisciplinary discussion is key. So we discussed these at Colorectal Cancer Tumor Board with one of the peritoneal surgeons, and then we make a decision. So I found this algorithm nice. So this is from a recent publication. So this is for goblet cell carcinoids or goblet cell carcinomas. So I still call them carcinoids. And so you stage them, and if there is macroscopic evidence of disease, you can sometimes offer them chemotherapy with FOLFOX or FOLFIRI. They may have a response. And if there is no evidence of metastatic disease, or if the metastatic disease is also intra-abdominal, you can consider induction chemotherapy followed by CRS and HIPEC. For localized disease, again, we can do right hemicolectomy, and if there is nodal involvement, higher grade, we can consider adjuvant FOLFOX therapy. We have done that, and we frequently do. Then the argument is, well, how long should we treat them? Should they get FOLFOX or should they get KPOX, 3 or 6 months? And I will not get into that. So, and if there's no evidence of tumor in any of the lymph nodes, and it's a T2, T1, T2, or even T3, you may just follow them up without any further therapy. Okay, so just finishing up here with neuroendocrine tumors. So these tend to be well differentiated, often incidentally found. I actually see a surprising amount of these in consultations. Oftentimes, seems like the typical person is like a young female who has appendicitis, has an appendectomy, and a neuroendocrine tumor is found, and they come to me and say, well, what do we need to do in terms of follow-up and more surgery and whatnot? So the outcome after surgery is absolutely outstanding if these are small tumors, but there are some nuances that I want to make you aware of. So the common question is really right hemi or not. So look at the size of the tumor. If the neuroendocrine tumor is less than 2 centimeters, well differentiated, they are very unlikely to metastasize. I did not include a study that was published yesterday, or I saw yesterday, and there actually, and those between 1 and 2 centimeters, there actually are, I think there are like 10 or 15% of them have nodal mets. And then you look at the grade, and there's a new grading system forthcoming. It won't change much for these tumors. The location, most of them are at the tip. If they're at the tip of the appendix, it's good. If they're at the base of the appendix, they're more likely to come back. And you have to orient the pathologist to the location of the tumor within the appendix, and you ask them to look at the mesoappendiceal invasion. So the mesoappendix has to be looked at. If the tumor extends 3 millimeters or more into the mesoappendix, the risk of nodal metastases goes up. And if you look at the ENETS guidelines, the European Neuroendocrine Tumor Society guidelines, they actually recommend the right hemi for them. So I initially started with the NCCN guidelines, and for full disclosure, I am on that panel. And then I came across this paper, which actually I found better in terms of explaining the sort of my workflow in my clinic. So if you have tumors that are the tip or the middle of the appendix and they're less than 1 centimeter, you do a simple appendectomy and you are done. You probably don't even have to follow them. If the tumor is at the base, more than 3 millimeter mesoappendiceal invasion and incomplete resection, you do a right hemi. For tumors between 1 and 2 centimeters, if they are at the tip or middle of the appendix, to look at the lymphovascular invasion, mesoappendiceal invasion, and if that's there, you do a right hemi. If they are more than 2 centimeters, you just do a right hemi, and then be done, hopefully. So, and then you follow them, and we can argue back and forth on how to follow them. I tend to do a CT scan at 1 year, a chromogranin, maybe a year or 2 or 3 years later. Sometimes, depending on the details, I may do a CT scan 2 or 3 years after surgery, and then I just call it a day. So let's summarize. So for lamins, small localized tumors, simple appendectomy. For tumors involving the periappendiceal area, 2 centimeters or larger, higher grade tumors or T3s, you do a right hemi after the simple appendectomy if that was done first. Pseudomyxoma peritonei, CRS and HIPEC. And then for some of those higher grade, higher risk localized tumors, you could probably consider CRS HIPEC. And systemic therapy, the role there in lamins is uncertain. As for appendiceal adenocarcinomas, low-grade, low-stage disease, simple appendectomy probably enough. Higher grade, higher stage tumors, right hemi, node positive, right hemi plus adjuvant chemotherapy, metastatic colorectal cancer-like chemotherapy, and then CRS HIPEC for selected patients. For the mannix and goblet cells, again, very similar. I'm just going to click through these here. So it really follows the same pattern as I showed you in the previous two situations.